Okay, so Dr. Jennifer Jones is the director of the Cancer Rehabilitation and Survivorship Program at the Center for Wellness and Cancer Survivorship, Elixir, which is where you guys are right now, at the Princess Margaret Cancer Center. In addition, she is a scientist in the Ontario Cancer Institute and an associate professor in the Department of Psychiatry, Primary, and the Dalla Lana School of Public Health, cross-appointment at the University of Toronto.
So thank you so much for having me today. It's my pleasure to be here. This is a great group. You guys, how are these seminars going? You're enjoying them? Good. So, and I guess you're from all different backgrounds and programs and everything. It's a very interdisciplinary group here. Okay, excellent. So that's great. So what I want to do today is just give you a little bit of background on cancer rehabilitation survivorship, why it's important, and then talk to you a bit about our program here at Princess Margaret, so you're familiar with it. Let's see if this will work. All right. So this shouldn't be anything new to you, hopefully, but just about how common cancer is. So two out of every 5 Canadians will be diagnosed with cancer at some point in their lifetime, and in 2006 they predict just over 200,000 new cases of cancer will be diagnosed in Canada. When we look at who it is that's getting diagnosed with cancer, cancer is primarily a disease of aging, and so you'll see it more often in people who are over the age of 65 years old. So 2/3 of people with diagnosed with cancer are over the age of 65 years old. And we also know that we have in Canada an aging population. So it was only a couple years ago that the first cohort of you know who the baby boomers are? Okay. So the first cohort of baby boomers turned 65. And so and all of these people are now coming into that age where they're at the highest risk for cancer. So the result of this is that we expect over the next 20 years, the percentage of people over the age of 65 will nearly double in North America, and this will actually double the number of people who are diagnosed with cancer in North America by 2050. So this is a huge issue, big problem, because our cancer systems are already pretty full. If you've been in any of the clinics, you know what I'm talking about. We already are, so we have to think about how we're going to address this growing number of people. We have to think about new health systems, the way that we have to think about discharging patients, because right now, typically patients come for many, many years for follow-up care after their treatment ends, and some people are coming here for 10 or 20 years for their follow-up appointments, and they probably don't really need to do that, and it takes up space for the new patients that need to come in. So we have lots of challenges that this will pose to our cancer system. But there is some good news in all of this. Even though we have many people getting diagnosed with cancer, this number is going to double. The mortality rates for cancer have dropped significantly over the past few decades. And this is primarily due to, first of all, tobacco control, so less people are smoking, but also we're getting better at detecting cancers early on. So they are typically diagnosed with early stage disease now, which is much easier to treat. And we have much better treatments. So as you know, if those of you who are in drug development or working in any of the drug trials here this summer, or in surgical trials or any radiation trials, the treatments for cancer are constantly evolving and improving. So that's great. And we have seen incredible improvements in the efficacy of these treatments, and the introduction of new treatments like immunotherapy and those kind of things. So on average, about 2/3 of cancer patients can now expect long-term survival. And I know this is kind of hard to read, but actually you can find this on the Canadian Cancer Society website. But just what I wanted to highlight, though, is that even though that overall statistic says 2/3 of patients can expect overall survival, that's across all disease sites. But when we look at some of the more common disease sites, we have much better survival rates. So for example, if we look at, I'm going to try to do this with the mouse here. So this is just highlighting with breast cancer patients. So the 5-year survival rate for breast cancer is actually closer to almost 90%. And when you're looking at early stage disease, it's even higher. So that includes all stages. Here, I think this is prostate, and it's nearing, like it's over 95% 5-year survival for prostate. The one down here is for GI, so colorectal, which is at around your 2/3 estimate. And other diseases like, for example, testes cancer, where even if you're diagnosed with advanced disease, it's very curable. So they have survival rates of 99%. So that's fantastic. It's great news. But again, it introduces new challenges to our healthcare system and our cancer system, which is primarily set up as an acute care system, right? So our focus of our cancer system historically has just been on the treatment, and it hasn't really been on what do we do once treatment's over. So when we look at the cancer trajectory, so basically people get diagnosed, they're staged, they're either treated with intent to cure or go into palliative supportive care. For those people who are treated with intent to cure, once treatment is over, they go into this sort of what we call survivorship phase, where they're either have disease-free remission, or in some cases, some people do have intermittent disease where it comes back, gets treated again, goes back into remission, or sometimes people have a stable metastatic disease that they can live with actually for many years. Like, for example, with kidney cancer, some people can have metastatic disease for 15 or 20 years. So in that case, you know, we sort of consider them in this survivorship sort of holding pattern. But at some point, treatment may fail, this cancer may come back, and the patient then would be looped back to palliative care. Hopefully, for most people, they stay in this disease-free remission, and then at some point, they get transitioned away from the cancer system. Yes, you have a question?
Yeah, so I think this is an interesting diagram of cancer survivorship. I think, though, that we could look at prevention and screening as important steps before diagnostic and staging, because with organizations like the Canadian Cancer Society, I think the general public is becoming increasingly aware of their risks for cancer, and they may fear it, so it plays a part of the psychosocial picture of cancer and how it affects our lives early on.
Yep, oh, for sure, for sure. I agree, and I think, you know, we haven't historically put a huge emphasis on the, you know, prevention and pre-cancer diagnosis, and we definitely need to. This is more within like our clinical systems and our cancer system, like our Princess Margaret system and stuff, how we're set up, and you know, their focus isn't really on prevention, whereas maybe Canadian Cancer Society, that would certainly be within their realm of thinking about that. So thank you for that comment. Okay, so you know, we see lots of these, you know, I beat cancer, I'm a warrior, I'm a cancer survivor, you know, you see these people wearing buttons and things. You know, I just highlighted some of these things here, like, you know, there's like, people have parties for it, they have buttons, you know, I'm a cancer survivor, what's your superpower, all these kind of things, right? So there's lots of people who are proud of overcoming their cancer and getting through their treatment and everything like that, and coming out at the end, you know, alive, basically. But we know that over the past few years, past several decades, with the growing number of survivors, people have started to look at, well, what's the quality of life of these people after treatment, and what are the issues that they struggle with? And we know that all of these cancer treatments, all of them, surgery, radiotherapy, chemotherapies, that we give to people do have an impact on people's well-being. So it can impact both them physically as well as psychosocially. So there are two ways that we think about side effects of treatment. There's something called persistent effects as well as late treatment effects. So persistent treatment effects are the things that happen during treatment. So for example, fatigue. Somebody who's on chemotherapy may develop fatigue. It's very common. You know, a large majority, almost 80–90% of patients will get fatigued during their treatments. For most people, that fatigue, once treatment ends and a couple months have passed, that fatigue will go away and they'll start feeling back to normal. But there's a substantial minority of people who that fatigue doesn't go away. It seems to persist and it lasts for many, many years after their treatment ends. So that would be something that we would call a persistent treatment effect. It's something that's happened during the acute phase but does not go away, so it persists. Whereas there are other things called late effects, which are new side effects that can happen months or even many years after your cancer treatment ends. And these things can be like cardiac side effects, you know, sometimes people have neuropathies, things like that. So different things that can happen to people that just sort of come out of the blue. And they're common. These things, these persistent or late effects are common. They're numerous, but their knowledge, we don't know a lot about them, about who's at risk for them. Why do some people get these and some people don't? So we still need to do a lot of research on this, and it is challenging because the treatments are changing all the time, right? So if you're going to do a long-term study for 5 or 10 years looking at the late effects of a treatment, by that time we're on to all new treatments again. So it is a challenge to sort of be tracking these things. We do know that there are some people who are at higher risk for persistent late effects. For example, people who have other comorbidities, people who are older. There are certain genetic risks as well. And we also know that behavior and lifestyle can play a really important role in helping to manage some of these things or prevent some of these late effects. So I know when we think about public health and public health of our cancer survivors, our focus has changes from during treatment and during cancer treatment, our focus really is on sort of mortality and saving a person's life. But when we think about cancer survivorship, our focus is a lot more on disability. And from a public health perspective, disability has really is now considered more important or as important as mortality. And so there's now this sort of big focus on overall sort of quality of life and disability of this group of patients. And just to highlight some of the physical effects and well-being effects. So certainly all cancer survivors, anybody who's had a cancer diagnosis, they're at risk for local recurrence or distant recurrence of their treatment, as well as any sort of second primary cancer. So some of the treatments that we give to people actually increase their risk of getting another cancer. So that's what, when people are coming for their follow-up surveillance appointments, that's typically what the oncologists are doing, is doing surveillance for recurrence of the disease or a second primary. But we know that treatment can also affect almost all of our different body systems and result in these persistent late effects. And these can, as I said, they can affect things like your cardiac and respiratory systems. It can result in cognitive impairments, pain, fatigue, neuropathies, functional limitations, sleep disturbances, sexual dysfunction, infertility, and then depression, anxiety, which are actually under psychosocial. But what's very common is that people have more than just one of these. In fact, people often have sort of symptom clusters of things where they would have fatigue and sleep disturbances with depression and pain, and all sort of clustering together. So it's not uncommon that patients would present with, you know, 4 or 5 different persistent late effects that they're struggling with. We know there are other effects of our treatments that we give to people. Sometimes we think of cancer patients very wasting and getting very thin and stuff, but in fact, some of the treatments that we give to people can result in weight gain. And so, for example, in the breast site, we see it very commonly that women actually gain weight, significant amounts of weight during their treatment. So not only is there, they don't like this for a body image point of view, but also it does increase their risk for their cancer coming back and for a second primary when they become overweight or obese. So weight gain is something that we really think about as well. Overall, though, when we look at like the overall picture of cancer survivors, we know that they appear to be functioning fairly well. Most are able to get back to work. Some finish treatment and they walk out of here and they're perfectly fine and get back to work, and other people struggle. We do know that, you know, in general, though, people have some functional limitations. So some people, they may not have the same stamina that they had before. They may you know, not be able to walk as far as they used to be able to walk. So there are some functional limitations in their lives. Sorry, I don't know why this looks like this. Oh, here we go. Okay. So this is just an example of, and also based on the disease site, as well as the different treatments that you get, there are all different persistent and late effects associated with those. So this is just an example of, you know, the types of side effects that you may see across different disease sites. So for example, in breast, it's very common to see lymphedema because of the surgery. Radiotherapy can cause this lymphedema in the arms, okay? Shoulder dysfunction is very common after breast surgery. And then there's body image issues in this population. Those are common issues. In prostate, we're looking at erectile dysfunction, urinary incontinence. There's shortness of breath in lung sarcoma. We're looking, there's issues around limb dysfunction. People have amputations and have to adapt after that. And then in head and neck, you know, obviously there's issues around, we still see swelling. We can see lymphedema in head and neck. Speech disorders, swallowing disorders, those kind of things based on the treatments that they have. So lots of these things that are, these are long-term things that people have to struggle with. Okay, sorry. And there have been some pretty large studies over the past few decades, sort of trying to compare cancer survivors to normal, other, you know, age-matched controls. And so this was a large one. Done NHIS survey that was done where they compared a large sample of patients who had had some cancer history versus those with no cancer history. And basically what this shows is just, if you're looking at the first bars here, this is fair or poor health. So this group here, this gray bar is the cancer survivors, and these are people who have had no cancer history. So, you know, about a third of people are saying that they're in only fair or poor health. 11% have more than one limitations of their activities of daily living. A large percentage, so almost 60%, have some kind of functional limitation in their life, and 17% are unable to work. And actually, this is a really important issue, is this issue around change in employment or getting back to work after your cancer treatment. And we see that lots of people struggle with that. They have fatigue, they have different things that it makes it difficult for them to get back. And so you see that, you know, a lot of people coming in, or a lot of people coming into cancer treatment are working, they have their cancer treatment and their diagnosis, and either they start early retirement, they go on long-term disability, and, you know, there's huge financial implications to all of this for people too. So work status is a really common thing that we see that people struggle with that changes. This is a National Health and Nutrition Examinations survey, and really basically just highlighting the same thing, where they looked at people who are cancer survivors versus no cancer history. And again, you're seeing much more performance, physical performance limitations and participation restrictions in our cancer survivor population. And this is a study actually that we did here at Princess Margaret, where we looked at breast, colorectal, and prostate cancer patients. And sorry, this is cut off here, but the pink bar, which it looks more pink on this screen over here, is people in the sort of first year post-treatment, and then these people in the middle are people who are 2 to 3 years post-treatment, and then, or sorry, up to 5 years post-treatment, and then these people are sort of 5 years or more, or sorry, 5 to 6 years post-treatment. So, I mean, basically what you see is that fatigue levels don't seem to be different in these three cohorts, and about a third of patients are experiencing significant fatigue even at 5 years post-treatment. So, and why this is important is that we know that people who have fatigue have very, very significant disability. It really impacts on their ability to see their friends and go to work and do the things that they want to do. So when we compare people who have moderate to significant fatigue, which are the people in the blue and the yellow bars here, moderate to significant disability, which is the blue and the yellow, and this is the people who don't have fatigue, and these are the people who do have fatigue. So basically, to interpret this, so 30% of people who don't have significant fatigue are experiencing moderate to significant disability versus 91% of those who are fatigued. So almost everybody who has fatigue also has quite moderate to significant disability. And we know that moderate and significant disability translates to very significant impairments in a person's life and their ability to just have a good quality of life. All right, and then psychosocial well-being. So not surprisingly, patients also report many psychosocial side effects of their treatments. You know, these can happen during treatment, where people, you know, have anxiety about their treatments, depression. But a lot of people talk about how more of the psychosocial issues really sort of come to light at the end once their treatment's over. So people often describe going through the cancer treatment sort of in an automatic mode, and then as soon as their cancer treatments end, they sort of get a flood of emotions of, you know, what's happened to me and all those kind of things. And at the same time that that's happening, they sort of lose their safety net of their healthcare team, where sometimes if they're getting radiotherapy, they're coming, you know, every day, and they're seeing their healthcare team every day, and they've got lots of support of their family and friends. And then as soon as cancer treatment ends, they don't come, we'll see you in 6 months, or we'll see you in a year. And the family and friends are sort of like, oh, your cancer treatment's over, everything's going to go back to normal. And this is actually a time where people say that they feel like they need support the very most, but they don't have it. And the things that people obviously, not surprisingly, lots of people have a fear of recurrence, especially when they're coming back for their follow-up appointments. You know, they get quite anxious about that. Is my cancer coming back? You feel a little pain here, feel a little pain there. We wouldn't think anything of that. But somebody who's had cancer might think, is that my cancer, has it spread? Has it come back? There's issues where people sometimes feel anger about what's happened, lots of uncertainty about what to expect. There are issues around sexual dysfunction, altered body image, changes in their relationships, and then just practical concerns, like I said, about returning to work and insurance discrimination, and financial implications. So this is just a quote, and this is actually from a physician who got diagnosed with breast cancer, and she wrote about her experience. So after my very last radiation treatment for breast cancer, I lay on a cold steel table, hairless, half-dressed, and astonished by the tears streaming down my face. I thought I would feel happy about finally reaching the end of treatment, but instead I was sobbing. At the time, I wasn't sure what emotions I was feeling. Looking back, I think I cried because this body had so bravely made it through 18 months of surgery, chemotherapy, and radiation. Ironically, I also cried because I would not be coming back to that familiar table where I had been comforted and encouraged. Instead of joyous, I felt lonely, abandoned, and terrified. This was the rocky beginning of cancer survivorship for me. So as you can see, I think this I think she does a very nice job of describing that feeling of sort of at the end of treatment, where lots of people are saying you should celebrate and, you know, ring that bell and wear that survivorship button, but people aren't necessarily always feeling that way. And about 10 years ago now, I can't believe it's already been 10 years, the Institute of Medicine, as a result of many sort of advocacy groups really raising awareness about this issue for cancer survivors and how people were sort of struggling, and there were no services or systems in place to help deal with all these problems that people were having after cancer treatment. They created a report and came out with this report saying, basically, not surprisingly, this is a neglected phase within our cancer care trajectory. It's underfunded. We don't have funding. That certainly we do a good job of monitoring for cancer recurrence and second cancers, but that we're not great at letting patients know about what their care is going to look like, what their course of recovery can look like, how to monitor for late effects, how to manage persistent side effects. And our cancer care system is really not very well coordinated for survivors who are going back to their family doctors and seeing other specialists, and people aren't really talking to each other. And there's actually, at this time, there were really no guidelines in place to help to inform what follow-up care should look like for cancer survivors. And so they did talk about these sort of 4 essential components of survivorship care, which include obviously looking at prevention of recurrence and new cancers, surveillance for these, coordination between care between specialists and healthcare providers, and also intervention for the consequences of cancer and its treatment. And so I've highlighted that because that's what I'm going to really focus on, is the idea of developing programs and interventions to help patients deal with these persistent late effects of cancer treatment. And so I'm going to start talking a bit now about rehabilitation and what that is and what we offer here at Princess Margaret for our patients to help sort of manage some of these issues that I've highlighted and really focus on that intervention piece. So rehabilitation in general, not specific to cancer, but rehabilitation is defined as a planned program in which the person progresses towards or maintains the maximum degree of physical and psychological independence of which they are capable. And we've probably, have you all heard of cardiac rehab or cardiac rehabilitation? Rehabilitation is a fairly common model in people who've had a heart attack or who've had stroke, multiple sclerosis, they use it. So there are other chronic diseases where rehabilitation has been applied successfully. In Ontario, we fund cardiac rehab, so anybody who's had some kind of a cardiac event gets referred to cardiac rehabilitation. But in cancer, it hasn't traditionally been applied. So in where we are starting to see, and I think when we go to Europe, they're far more ahead than we are actually here. So in Germany and in the Netherlands, they have very well-developed cancer rehabilitation programs. The US has started to develop some. And in Canada, there's a few small sort of community-based programs, but nothing implemented or integrated within large cancer centers. So it is fairly new. And cancer rehabilitation really involves helping a person with cancer to help himself or herself to obtain the maximum physical, social, psychological, and vocational functioning within the limits imposed by the disease and its treatment. And it's been shown, again, it's kind of small on that screen, but it's, cancer rehabilitation can really help with so many of those persistent late effects that I talked to you about. And here's another quote that I just wanted to pull out. I really like this one, really highlights the need for why we need to do this. So the experience of entering the medical system for many cancer patients is that they feel very good at the beginning. And then the treatments make them profoundly ill and often disabled. When they are sicker and more debilitated than they have ever been, they are discharged to follow-up care, which may include such things as routine screening for cancer recurrence, managing ongoing medications, and others, but this does not generally include multidisciplinary rehabilitation intervention. In effect, the medical system creates a situation where high-functioning individuals are given life-prolonging treatments and then left to struggle with how to recover from these toxic adverse effects of these therapies. So basically, you take a healthy person, you plug them into our cancer system, and you spit them out the other end, unhealthy and disabled, with nothing to help support them. So cancer rehabilitation really can involve many different things. So different cancer rehabilitations offer different things. Some of them really just focus on the physical interventions, like exercise, the dietary change, and are very physical or exercise, physical activity based. Some of them are more psychosocial interventions where it's about teaching patients self-management through patient education or doing mindfulness training, relaxation training, those kind of things. So they can include both of these components. There is probably the strongest evidence for the exercise or physical activity components of cancer rehabilitation. There's a huge volume of studies out there now really supporting the benefits of physical activity in cancer survivors and how they can improve many, many different outcomes. And there have been a number of now meta-analyses and systematic reviews on this. So this was one that was published in 2010 where they looked at 82 studies and they found a large to moderate effect of physical activity interventions post-treatment on upper and lower body strength and fatigue, and small to moderate positive effects for physical activity level, aerobic fitness, and muscular strength. And in another one that was done in 2002, looking at the effect of exercise on quality of life, they found beneficial effects on quality of life, cancer-specific concerns, body image, self-esteem, emotional well-being, sexuality, sleep disturbances, social functioning, anxiety, fatigue, and pain. So, I mean, there's actually a massive list if you compile all the studies in exercise and all the benefits to exercise, there's a huge list of the benefits that exercise can have. So I think I think the recommendation would be that any rehabilitation program really needs to include physical activity and getting people physically active. What people are starting to suggest now is that we probably shouldn't have a rehabilitation that includes just one or the other component, but probably includes all of these components. So multi-dimensional rehabilitation programs which include both that physical activity focus, but also the psychosocial components, knowing that there are a lot of psychosocial issues that the patients are dealing with, and also huge patient education needs in this population. And so, you know, there was a review that was done recently, and there haven't been a lot of these programs out there, so it's difficult to sort of do big reviews or look at the impact of these programs. But in this review, where they looked at multi-dimensional rehabilitation programs for adult cancer survivors, they did find that there was consistent improvement in their physical functioning following intervention. I thought this was a really helpful review when we were planning our program, because it talked about how you don't need to have site-specific rehab programs. You can combine all the different types of disease, cancer types together. So you can have breast cancer patients with prostate cancer patients and head and neck cancer patients all together in a rehab program, and it seems to be just as effective as if you were to separate them out. They do suggest that it should be face-to-face delivery, and you can supplement that with telephone calls or emails or whatever else. And that there doesn't need to be, these rehab programs don't need to be 6 months long. They can be fairly short and still be effective, so they don't need to be prolonged. So I'm just going to finish by talking just about our, can you just tell me at the time, Grace? 107. Okay, great. So this is, I just want to highlight a little bit about our cancer rehabilitation and survivorship program here at Princess Margaret, and just give you a background on the evolution of our program and you know, where we are today. So basically our vision of our program, and this is a fairly newly developed vision for our program, is providing compassionate and holistic impairment-driven cancer rehabilitation to patients both during and after cancer treatment at Princess Margaret. And our objective is to maximize people's quality of life, their functional independence, and their health and wellness. So this is just a little bit on the history of our program. So our program actually started back in 2005, so we've been around for 11 years now. And it started in the breast cancer program, out of the breast cancer site at Princess Margaret. So back then, I don't know if you've heard of the Weekend to End Breast Cancer, which is a walk that started back in 2004, I think. And it was a big weekend where people would go and they'd walk for 2 days and they'd raise money. And it was something that our foundation at Princess Margaret did. And the walkers themselves got to direct where some of this money that they raised would go and what programs that they wanted to support. And they were the ones actually that advocated for the need for a survivorship program in the breast site. And so some of the funds were directed to that. And we opened a small breast cancer survivorship program in the breast site at Princess Margaret. And if you go over to the second floor of Princess Margaret at the breast site, you'll see there's a nice little room off to the side of the clinic where that was really where we first started. And it's a beautiful little room, and then there's clinic rooms off of that where we can see patients. So that was 2005. And then over the next couple years, that walk changed. So it was first the Weekend to End Breast Cancer, and then it got changed to the Weekend to End Women's Cancer. So we were able to expand our program to the gynae site. And then we added also head and neck site because they brought some donor money. So our program is being entirely run by donor money. So it's always dependent on where we get our money from, which sites we were able to provide our services to. And over this time, we developed a number of different clinics that people could come to. So the first clinic was our lymphedema clinic, because at that time, lymphedema was very, very common. People were coming with huge swollen arms, a big issue. We don't see that as much anymore because it's getting caught a lot earlier. Surgical techniques have gotten better. And there's just more awareness of catching these things early on. We had a fatigue clinic, neurocognitive clinic, functional mobility clinics that we slowly rolled out over the years. In 2010, this space opened up because we got a large Canadian Foundation of Innovation grant to build this infrastructure. And this infrastructure, I think, is being just really transformational for our program because it allows us to do so many more things. You know, with the addition of the kitchen, have you all walked around? Have you seen the kitchen? We have a gym space. We can do fitness assessments. We can have these types of big group meetings. We can meet with patients in the living room area when you walk through and have support groups. And then our whole team is back here as well. So it's been just incredible to have this additional infrastructure for us. And following this infrastructure being built, we launched our Elixir Kitchen program, which I'll tell you a little bit about. And then after that, our Elixir Weekend, which is an exercise program. And then this year, we, up until then, we were called the Cancer Survivorship Program. This year, we've rebranded ourselves and completely changed the way that we deliver care, and we're now called the Cancer Rehabilitation and Survivorship Program. So I'll tell you a little bit about that. Our team is made up of quite a multidisciplinary and sort of interdisciplinary in that we overlap in a lot of our roles in our team. So we have a physiatrist who is, a lot of people don't know who a physiatrist, does anybody know what a physiatrist is? No? Okay, so a physiatrist is a medical doctor who is specialized in rehabilitation medicine. And there are very few physiatrists who have focused specifically on cancer. And so our physiatrist here, Dr. Eugene Chang, is the only physiatrist in Canada that has gone through the training program at Memorial Sloan Kettering and is a cancer rehabilitation specialist. So we're very lucky to have him. He's also a cancer survivor, so he understands a lot of the issues that cancer survivors have gone through. We have physiotherapists, we have a massage therapist that helps deal with the lymphedema issues, a dietitian, we have a neuropsychologist, occupational therapists, we have a social worker, and we have a number of kinesiologists too who do the exercise programming. So it's quite a big team. And this is just to show you, you know, from when we started in 2005 up until 2004, so in the first sort of 9 years, huge increases in the number of visits that we had and new patients that we were seeing each year. And as I said, we sort of, how we were structured was we had these sort of standalone clinics that people could be referred to. So as an oncologist, if you had a patient that had fatigue, you could refer to our fatigue clinic. If you had a patient that had a neurocognitive problem, you could refer to our neurocognitive clinic. But the issue with that is that, as I said, a lot of people don't just have one problem. They have fatigue and lymphedema, or fatigue and neurocognitive problems. And so patients were having to come and they'd go to the fatigue clinic and get assessed and go through that, and then they'd go to the lymphedema clinic and get assessed and go to that. And so it wasn't actually very patient-centric. And it was causing quite a lot of duplication of our efforts in terms of reassessing our patients. And in 2005, Princess Margaret changed our walk, again, the walk that has primarily funded us, to now called the One Walk. Have you heard of that? Hopefully you've heard of our One Walk, Princess Margaret One Walk, and hopefully all of you will take part in it this September. But it's One Walk to Conquer Cancer. And so our funding has changed now, so that walk is now raising money for all the disease sites at Princess Margaret, not just breast or gynae or women's cancers, but all disease sites. So our mandate has now changed so that we have to provide services to all the disease sites at Princess Margaret with the same number of people in our team. So that's a massive mandate, and I'm really excited about it because I think it's only fair that we offer our services to every person at Princess Margaret. And if you have, you know, bladder cancer, oh, I'm sorry, we can't see you, but if you have breast cancer, yes, we can. So we're not doing that anymore. We're saying that everybody can come to us. But that also provides us with massive challenges in terms of how are we going to manage this? How are we going to see all these patients? So we sort of this year went and sort of blew up everything that we were doing. And as I said, we've rolled out in March the first integrated cancer rehabilitation program in Canada. And our focus is really on managing those chronic and late effects of cancer with a focus on also secondary prevention, so promoting wellness. And we are doing longitudinal evaluation of the program. So I'll just show you quickly what that means. So basically, patients, if you look at this triangle, it's funny how they are like different colors on different screens. But if you look at this triangle here, you know, patients can get referred to our program. So now we just have one referral form. So the doctors don't have to refer to specific clinics. If they have any, they just refer to our program. And the patients will come in and we do a comprehensive assessment of that patient, and we figure out what the different needs are of that patient, whether they're sort of low disability, moderate, or high disability, and what are the different issues. The majority of patients actually are fairly low, have low disability, and so we can manage them in groups, through patient education, through our community partners, and we don't really have to do a lot of rehab with these patients. It's these people in the middle that we're really focusing on for our program who have sort of the moderate disability, moderate to severe disability, or multiple sort of persistent late effects that they're trying to manage. And then there's a very small percentage of patients who have very severe disability. So, for example, those patients who may have amputations and need new devices and those kind of things, or have completely frozen shoulders, and so it would be difficult to get them exercising because of that, or issues around balance and stability. So we, luckily, as part of UHN, Toronto Rehab Institute is part of our UHN family, so we can refer our patients to the musculoskeletal program there, have them have more one-on-one manual therapy, and then bring them back to our program. So this is really, if you think about it, we're just really triaging our patients a lot better now. And so this is basically the way it looks. Patients get identified within the clinic. They get referred to us. We screen just to make sure the patient is eligible. We do our comprehensive assessment with the patients. And then based on their level of complexity, they get triaged. So if their complexity is fairly low, their disability is fairly low, we just try to resource them. So we resource them to other programs within their community that are closer to home, and things that, you know, are already being offered very well by patient education or through wellness programs. Those people who are moderate, then we do some more assessments with them, and they get put into a structured rehab program, which is very similar to what you would see in cardiac rehab. It's an 8-week structured rehab program with a big focus on education, but also on physical activity and exercise. And then, as I said, those with very high would see our physiatrist and go over to TRI and see the patients over there. So I've just detailed this a little bit more. So those with none to low disability, they can go to community supports, wellness, and exercise programs here at Elixir or through patient education classes that are offered at the hospital. And we have lots of different support classes, lymphedema awareness, reclaim your energy, so people who just have a little bit of fatigue and need some just some pointers on, you know, how to manage it. For a lot of people, that's all they really need. They don't need to go into a whole rehab program. They just need to know what are some tips. And so those kind of group classes are a great way to do it. And for us, it's a lot more sustainable to offer things in groups like that. We have, as I said, our weekend exercise program. So this is a home-based program, so people can come, they can get a full fitness assessment, VO2 max testing, body composition, everything done with them, and then they get put on an exercise plan, they get an exercise prescription, they get sent home, they have bands, and they use an exercise ball, and they go home and they do their exercise program at home, and they can drop in for classes if they like, and we reassess them at certain intervals where we can then see how they're doing, monitor all of these outcomes, and also change their exercise prescription to sort of slowly ramp them up to where we want them to be. And we also have our Elixir Kitchen. Have any of you heard about this or seen it? No? Okay. Well, we have demonstration classes every third Thursday of the month, so you can drop in and get some free samples and see a fun interactive class with our wellness chef. So we have a wellness chef here as well as our dietitian. They do great live cooking demonstrations that are also live streamed, so people can watch it from home. We have a YouTube channel where you can see all of those. There's lots of great videos there, and also we have over, I think, 200 different recipes that are posted there. And we have, you know, a great Twitter followers, lots of Twitter followers and everything like that, so big social media component to it all. And the Elixir Kitchen's great. It's a great way to just promote wellness and healthy eating. But we also use the kitchen actually to try to address some of the late effects of persistent effects of cancer treatment. So, for example, right now we're offering a structured intervention for people who have had pelvic radiation that as a result of their pelvic radiation have bowel side effects. And so they end up restricting their diet very severely and not eating like proper balanced diet because they don't want to eat fruits or vegetables or anything with fiber that may end up just making those symptoms worse. So instead, what we do is we have them come in and we show them ways that they can prepare their foods. So it reduces the insoluble fiber, but they're still getting the nutrition that they need. So we try to use the kitchen in that way too. And as I said, we have this structured 8-week program. So people would come in for 8 weeks. They have an hour of exercise and then an hour class where they learn different skills. So focusing on things like fatigue, mood, relaxation, diet, mindful eating, and brain health as well. And so they go through this 8-week, and this is a group-based rehabilitation program, so we have up to 10 people in the group that are going through together. And then, as I said, people with high disability would go to TRI, and once they're medically cleared, they can come back to our program and get through that 8-week program. And I just want to finish by just talking about how our program also, you know, as with everything here at Princess Margaret, because we are a research institute as well, you know, we have a big focus on research. And I think because we're very lucky to have this wonderful funding for our program, and we're really the only place, actually this is a one-of-a-kind program in the world, I think it's also our responsibility to to collect data and to do research and to be able to share that and advocate for the development of programs in other places other than here. So anyway, we have sort of the themes of our research are so health services research. We do biopsychosocial research looking at the prevalence of these types of persistent late effects, who's at most risk, how can we develop interventions specifically to deal with those, self-management research as well. And we also actually lead a national consortium called the Canadian Cancer Survivorship Research Consortium, which is a group of researchers across Canada who are interested in cancer survivorship and rehabilitation, so I co-lead that. And we do monthly webinars where people get together and present their research findings and have discussions around that. So, so I think, you know, we can really see ourselves as helping to grow this area of research and to support other people who are involved in it. So I hope all of you will, hopefully this was very helpful for you and that you learned a few new things today. And I thank you very much, and I'm happy to take any questions that you may have.